My name is Ethan Bryson. I'm an associate professor of anesthesiology and psychiatry at the Mount Sinai School of Medicine in New York. The article I will be discussing is entitled Buprenorphine Maintenance Therapy in the Opioid-Addicted Healthcare Professional Returning to Clinical Practice, a Hidden Controversy. The article was written by Mrs. Heather Hamza and myself and published in the March 2012 issue of the Mayo Clinic Proceedings. In this paper, we investigate the current use of buprenorphine maintenance therapy in the opioid-addicted healthcare professional who wishes to return to clinical practice. Currently, there is no consistent practice when it comes to this issue. Some states allow re-entry on buprenorphine, while others are adamant that its use in this context remains strictly forbidden. Many states do not have an official policy, preferring instead to take a hands-off approach and allow the treating addictionologist to make the decision. Given the controversial nature of this topic, it is not surprising that several states have demonstrated a reluctance to share their practice or policies with us. Buprenorphine is a semisynthetic partial mu opioid agonist and a kappa receptor antagonist that is currently used for analgesia and to treat opioid dependence. Buprenorphine's use as a treatment for opioid dependence was first approved in France in 1995, and it currently has approval for such use in 44 countries worldwide. Compared to full mu-agonists, it is believed that buprenorphine has a safer pharmacodynamic profile due to its slow dissociation from mu receptors as well as less potential for respiratory depression. Despite these positive attributes, there are still some potential problems with the use of this drug in the healthcare professional who is considering a return to clinical practice. Buprenorphine is only a partial mu-agonist, but still induces the same physiologic responses as full mu-agonists, including cognitive and psychomotor impairment, memory deficits, meiosis, respiratory depression, decreased gastrointestinal motility, urinary retention, and nausea. As well, it has been reported by users to have euphoric and drug-liking qualities, and is associated with drug dependence and subsequent withdrawal. Many clinical trials have assessed the psychomotor performance, decision-making ability, and neurocognitive functioning of patients under the influence of buprenorphine. Findings suggest that buprenorphine decreases performance on several cognitive tasks, in particular the encoding and delayed recall of verbal information. The majority of the studies evaluating the effects of buprenorphine maintenance show some degree of impairment when participants are subjected to a variety of tests designed to assess particular nuances of higher cerebral functioning. Many studies compare performance on buprenorphine versus methadone, clearly showing that while buprenorphine causes less impairment, it still causes impairment to some degree. Unfortunately, evidence is lacking in the very specific population of healthcare professionals maintained on this medication. Studies need to be conducted that evaluate participants' ability to perform tasks specific to those required of healthcare professionals while on buprenorphine. These studies should involve standardized patients or operating room simulation, utilizing realistic scenarios that require rapid analysis and action, complex decision-making, eye-hand coordination, and fine motor skills. Abstinence from all potentially addictive drugs remains the gold standard for healthcare professionals in recovery. The overwhelming majority of professional health programs which use an abstinence-based model for physicians in recovery report success rates far in excess of other programs. There is a long history of success using this abstinence-based model, and the most recent data reported only 22% of physicians testing positive for drugs of abuse at any time during their 5-year monitoring contract, and fully 71% remained licensed and employed 5 years after their initial treatment. In certain situations, potentially addictive drugs can and should be used when the benefit outweighs the risk, but in most of these cases the situation is acute and generally time-limited. In the case of healthcare professionals in early recovery who are not working clinically, patient safety is not compromised, but the longer-term use of these potentially addictive medications is problematic. The inability to remain abstinent without opioid replacement therapy is often associated with multiple relapses. While these medications can be widely used to help retain people in the detoxification phase of treatment, maintenance is another matter and indicates severe difficulty with maintaining recovery. More importantly, these drugs may actually be psychotoxic to those in recovery, and inability to remain abstinent without opioid maintenance therapy may be a potential predictor of increased risk for relapse. There exists a need for clear-headed, chemically abstinent healthcare providers, especially in fields such as anesthesiology and emergency medicine. When considering all of the aforementioned issues with buprenorphine diversion, it does not seem reasonable to prescribe this medication to a healthcare professional with a history of opioid addiction. After carefully considering the evidence, we believe that opioid substitution therapy with buprenorphine is not a reasonable choice for this particular patient population. Healthcare professionals are engaged in exquisitely safety-sensitive work that requires vigilance and full cognitive function. We therefore recommend abstinence-based therapy until studies with a specific healthcare professionals population carried out in a simulated healthcare environment documents that highly safety-sensitive tasks can be performed without deterioration in performance.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.